It's 8:02, so why don't we get started? Good morning, everyone, and welcome to Geriatric's Grand Rounds. I have the great pleasure of introducing one of my most inspiring colleagues here, Dr. Russell Berg. He and I were colleagues during internal medicine training, and he is an internal medicine doctor who's been doing really incredible work with hotel shelters and field-based teams through Harborview Adult Medicine and Pioneer Square. So I'm going to take it over to you, Russ.
Thanks so much, Ruru. Hi, everyone. I'm Russ. Thank you for that introduction. I'm a member of the Harborview field-based teams and practice here at Mary Pilgrim Inn, which I'll tell you all about. And it's an honor to be asked to present today at Geriatric's Grand Rounds. And today's topic will be the intersectionality of aging, disability, and homelessness. I have no conflicts of interest to disclose, and again, wanted to thank Ruru for the invitation. It's very kind to reach out and wonderful to see you again after these years. Here's a brief outline of my talk today. I'm going to give you a little bit of background on homelessness in our community. We're going to talk about how those experiencing homelessness are aging throughout the country. Then we're going to talk about the provision of homeless services in King County and how that changed in the context of the COVID pandemic, specifically the creation of hotel shelters, of which Mary Pilgrim Inn is one of them. Then I'll give you some more detail on exactly what Mary Pilgrim Inn is and what our medical clinic does. And then dive into some cases. I'm going to touch upon some cases about aging and schizophrenia and associated disability for some of those individuals. We'll touch on a case of a minor medical mystery, a little bit of a lighter flavored case, and then wrap things up with a case that we did at a previous hotel shelter called the Red Lion Hotel Shelter, a case where we were able to accomplish home hospice in the hotel shelter setting. So first, some background on homelessness in King County. I think everyone who lives or works in Seattle or the Seattle area, unfortunately, is pretty familiar with this scene. Sidewalks or open spaces like parks or unused parking lots filled with clusters of tents. This is a picture from the Seattle Times downtown near Pioneer Square, but these are unfortunately in every neighborhood. And is something that we see more and more often these days. It's impossible to ignore. Per capita homelessness, this is a list of the cities in America with the highest rates of homelessness. And you can see Seattle is right there, along with other major cities, just a little bit fewer than New York City or Los Angeles. But with other major cities, and as you can see, a lot of the cities with the highest rates of homelessness are concentrated in the West Coast. This data, by the way, is from 2018, so it's increased since then. How do we measure prevalence of homelessness? How do we know how big the problem is for individuals experiencing homelessness? The King County Regional Homeless Authority, which is a administrative body in King County that tries to help organize homeless services, does an annual point in time count, PIT, and they send out a whole army of volunteers to go really search the city for unsheltered individuals, people sleeping in cars, sleeping in tents, or, you know, really just out in the open. And found the last time this was done was 2022, found that over 13,000 individuals were counted as experiencing homelessness. So that's kind of just a snapshot in time. If you try to annualize that figure, right, because some people are transiently homeless and might not have been captured in that one-time count, it works out the last time these numbers were crunched for 2020, that almost 41,000 individuals in King County experienced homelessness sometime in 2020. Of those that were surveyed, about half identified as having a disability. About a third identified as having a mental health disorder, and over a third identified as having a substance use disorder. When you divide this number by the population of King County, you get a pretty stunning figure. Almost 2% of King County residents experienced homelessness at some point in 2020. That's really an incredible thing, and a terrible thing. And if you think the prevalence is going up and you're seeing more tents on the street, that is correct. Your impression is accurate. Between 2007 and 2022, King County's total homeless population increased by 70%, 0%, indicating no growth in shelter beds, and the unsheltered population increased by almost 250%. So you really are seeing more people who have no better option than to sleep on the street. It really is a humanitarian disaster that's unfolding before our eyes, in every neighborhood of our city and of our communities. People experiencing homelessness are also aging, and it turns out that chronic homelessness disproportionately affects late baby boomers, so individuals born between 1955 and 1965. This graph here on the right shows distribution of ages for um, individual single adult males who are homeless in this survey. And the last time this was done, the blue line was in 2010. You can see that the peak of this curve has been moving to the right, has been aging as this cohort of late baby boomers has been aging. And now we expect this peak, now that it's been about 13 or 14 years since this graph was produced, these individuals are going to be in their 60s to 70s, the peak of this curve. So chronic homelessness really is a problem for aging adults. And currently, those individuals we'd expect to be um, overly overly represented in the ages of about 60 to 70. Older homeless adults have rates of cognitive decline and impaired mobility comparable to individuals 20 years older. It's pretty stunning. We know those who work in the field of homeless medicine with individuals experiencing homelessness know that they look older, they suffer from chronic illnesses at an accelerated rate, and also suffer from diseases of aging such as dementia at a much earlier age, and that's about 20 years younger. So if these folks are 60 to 70 years old, they kind of have a biological age of greater than that, maybe 70s to mid 80s or even 90s. In one study in Oakland, California, unhoused individuals who are 50 years of age or older had a 3.5 times the mortality rate of housed controls and a median age of death of 64, which is much, much earlier than we'd expect for the general population. Things really changed in regards to the provision of homeless services. Hear this headline from the Seattle Times. To prevent coronavirus spread at shelters, King County will move nearly 400 people into hotels. This is a picture of what the old congregate shelter used to look like in Pioneer Square. And this was DESC's large low barrier harm reduction shelter with 200 men in this single room here, 50 women in a different dormitory down the hall. And this was closed to prevent the spread of COVID-19 in 2020. And all of these individuals were moved to a hotel that was rented by the county in Renton. Um, I was hired to start working in that setting, and that's where I started working about 4 years ago. And this work is really the evolution of a longstanding collaboration between DESC, which is the Downtown Emergency Services Center. It's a large NGO in the county that is a major provider of homeless services, shelter, and permanent supportive housing. And we've had a long collaboration between Harborview Medical Center and DESC to provide medical staffing to that shelter, typically in the context of a full-time nurse and a part-time provider. One of the longest serving nurses in that position was Mary Pilgrim, for whom the current hotel shelter, the Mary Pilgrim Inn, is named. This is a picture of Mary Pilgrim Inn. It's where I'm giving this talk from today. It's a former Holiday Inn Express that was bought up by the county. We house 100 residents, all of whom are chronically homeless and with medical complexity. It's a low barrier harm reduction based shelter. And we offer enhanced services, case management, medical services on site, and a crisis respite program for recent psychiatric discharges. We have medical staff on site, and it's funded through the King County Health Through Housing Initiative, which is a sales tax. Here's a picture of our medical clinic. It used to be the old gym. And you can see we've divided the space into some bays, kind of like with these long ER type curtains. We have 2 full-time nurses and 2 providers on site. And the clinical services we offer are quite broad. We're emergency first responders. We provide urgent care and walk-in services. We try to provide primary care for those who don't have primary care doctor already. We do hospital follow-up, low barrier medication refills, a lot of wound care, low barrier treatment for substance use disorder and mental health, and also do a lot of our own lab draws here on site. This is our patient population is majority male, which aligns with the majority of those facing chronic homelessness are single males. And our demographics, our age demographics, I think are also interesting. We actually have, compared to those red, green, and blue curves that I showed you before that showed a peak in individuals you'd expect to be in their 60s or 70s now, we actually have a younger peak here as well of individuals from, kind of Generation X in their 40s and 50s. And those people probably represent here individuals who are coming to us from encampments, which tend to be comprised of individuals who are younger and who are better able to survive outside. And so I think that's why our population is actually a bit younger than you'd expect, given the overall demographics of those facing chronic homelessness. Our median age is 52, and about 14 or 15% of our individuals are 65 or older. So with all our services and our medical staff, where does Mary Pilgrim Inn fit into the safety net? There's a lot of arrows here, and a lot of those go back and forth. But basically, Mary Pilgrim Inn receives referrals from the emergency department, from high utilizer case managers in the ERs. We receive referrals directly from safety net inpatient discharge planners like at Harborview. We receive referrals from medical respite, from the bed-ready nursing homes that are part of the Harborview and King County safety net as well. We accept a lot of individuals who are discharging after an involuntary psych admission. And finally, we also receive a lot of referrals from the community. Those are referrals placed by outreach workers or case managers who are outreaching people in encampments, for instance, or people who are literally homeless on the street. And their referrals are accepted, and we place those individuals here at Mary Pilgrim. And the goal is for everyone here to eventually achieve permanent housing, whether that's independent living, permanent supportive housing, or a higher level of care, such as an adult family home or assisted living. Our medical referrals come from a lot of hospitals in the community, and over the last year, we've accepted over 80 medical referrals, over 40 of which were from inpatient units and over 25 from medical respite. The majority of our referrals come to us from Harborview or from Harborview Medical Respite. Of the Mary Pilgrim Inn Clinic, we seek to provide low barrier care that empowers and enables independence. And if a patient cannot be independent, we work to formulate a clear plan to support them in a sustainable way until long-term care is available that's appropriate for them. We seek to improve the health and well-being of our patients. We work to stabilize chronic medical conditions and to treat acute medical needs. And then through this work, hope to reduce unnecessary impacts on 911, emergency departments, and hospital beds. We work to diagnose conditions and identify medical needs that impact housing disposition and try and really get the process started and on good footing. A lot of folks who come to us have been chronically homeless for a long time, like, 10 years, and really have not been able to stay in one place long enough to get traction to achieve their goals for independent living. So this is our model of care. We're really seeking to provide the intersection of between care that would benefit the patient, such as primary care services, specialist services, preventative care, outpatient mental health, the intersection between that and care that our patients can accept, which sometimes is very low barrier, outreach, room visits, harm reduction based care for dangerous substance use, and also within the context of the care that Mary Pilgrim can provide. And I think our range of services is quite broad and also quite deep. I've mentioned some of the medical services we provide, but we also provide some outreach psychiatric services. We have a member of the Harborview field-based teams, Dr. Nora Asali, who does outreach here. And we also work to integrate people with other community mental health programs. So after that introduction, I wanted to move to a couple of cases and discuss a couple of cases that highlight some of the challenges and strategies we use to help some of our patients who are aging and who have schizophrenia, which is a relatively common combination of morbidities here amongst our patient population. Again, our population is enriched for aging boomers, individuals in their 60s to late 70s now. And it's thought by 2030, those over the age of 65 with a major psychiatric disorder will be young to those aged 30 to 44. I think we often think of serious psychiatric disorders or even schizophrenia, certainly as with typical onset in early adulthood. And we often think of it as a disease of the younger. But actually, given the aging demographics, pretty soon we'll have equal numbers of elderly with major psychiatric illness compared to those who are younger. Older patients also may manifest different symptoms of schizophrenia compared to younger patients. Older patients may have fewer and less severe positive symptoms, such as hallucinations or delusions, but the negative symptoms of schizophrenia tend to persist, such as withdrawal, social isolation, or even catatonia. There's special challenges to treating schizophrenia in the elderly, besides the kind of perhaps slightly less typical presentation for psychosis. There's also specific considerations, such as that the rate of tardive dyskinesia is greater than 50% in the elderly after 3 years of treatment with a typical antipsychotic. So the rate of permanent side effects, irreversible side effects, is very high in older individuals who might be receiving a medication such as Haldol. Atypical antipsychotics, things like olanzapine, are associated with an elevated risk of mortality in those with dementia. There's a 1.6x risk of mortality and an increased risk of stroke as well in older people with dementia who are given atypical antipsychotics. So our kind of standard medications are just harder to use and potentially less efficacious in this population. I'm going to move on to a case that I think highlights some of these challenges. This is a 78-year-old man with psychosis and progressive dementia. He was released from a 30-year prison sentence in 2013 at the age of 71, so spent the majority of his adult life in prison. And then when he was released from prison, he seems to have been unstably housed. There's really not much medical record. He did not have much interaction with the medical system, but he seems to have been unstably housed and intermittently homeless during this period. He did end up in the hospital in 2021, where he was admitted for urinary retention and psychosis at that time. And he was discharged to our hotel shelter in April of 2021, directly from that admission. So this plot here, I just want to give you a little bit of orientation to. This is a plot of cumulative hospital days for this individual over time, with time on the axis on the bottom there. Those are dates, and each tick mark is separated by 1 month. And this is just keeping a cumulative tally of every hospital day. So presentation to the ER counts as 1 day. If you're admitted, such as this diagonal upsloping line, each subsequent hospital day is tallied there. And it's just a way to kind of visualize someone's utilization of hospital services. So he had this prolonged admission in March of 2021, and that's this upsloping line here, and then arrived at the hotel shelter in April of 2021, where the second arrow is pointing to. The medical staff spent time getting to know him. He had encounters with us for back pain, for urinary retention, urinary tract infections, and was starting to demonstrate progressive symptoms of confusion. He had not had contact with his family for years. And other history we were able to get from him was he had prior heavy alcohol use, none now. And then the workup that was accomplished in the outpatient setting and during a couple of these ER visits that he had for increasing falls and confusion. He had a normal CT head, normal thyroid workup, urine toxicology was normal, blood alcohol level was also negative. And he was diagnosed in the outpatient setting with B12 deficiency, which was supplemented. However, and so that's kind of what our the plot looked like during that time. We were able to help him achieve some periods of stability, maybe months between ER visits or admissions, up to 4 or 5 months in this first bout. But he was starting to have some increasing admissions for and ER visits for falls and confusions. And during this admission here, initially for a urinary tract infection, he was diagnosed with dementia. So how can we help this patient? To reframe him, he's an elderly man with psychosis and progressive dementia and functional decline who cannot be placed. How can we work towards safe and appropriate placement for this individual? The case management team opened an adult protective services referral for him, and also DSHS referral was placed for evaluation and for placement in an adult family home or a memory care unit. Unfortunately, those referrals were not moving forward due to his history. He had for a sex offense. He was in prison for a sex crime, and that precluded his placement in these facilities, unfortunately. So how were we able to help him meet his needs while he was with us here? We worked on mobility aids to reduce the risk of falls. We got him a four-wheel walker with a seat. We got him a proper shower chair to minimize risks of falling in the showers and to help him take better care of himself. We increased the frequency of check-ins by both shelter staff and medical staff to monitor his nutritional status. And also we were able to arrange a visiting caregiver to help him with bathing and dressing in his room at the hotel here. And then a big thing we had to do was to continue to monitor him for decompensation, specifically his nutritional status and his ability to accomplish ADLs. It is a requirement here that you have to be independent with your ADLs. And so this was an individual who was really not independent with his ADLs anymore, and it was getting worse. But our efforts to find better disposition for him were delayed and were taking a long time. So you can see here if we continue the cumulative hospital day plot for this individual, the rate of his ER visits, which are these single dots here on the blue line, started to increase. And he was having more falls here, more confusion here at the hotel. In July of 2022, he was able to start the caregiver services here that I mentioned. However, he was wandering off more and getting lost. And after one of these ER discharges, he was discharged late at night from the emergency department. He was found at a bus stop early in the morning by the police, wearing inappropriate clothing for the weather, and was brought back to us very early in the morning by the police. On follow-up, he does agree to wear an Apple AirTag necklace so that shelter staff can locate him if he gets lost. He's really scared of getting lost. He knows he's getting lost and he wants help. And so he readily staff could use Find My AirTag to help find our patient if and when he left the hotel. However, this didn't last very long. And later that month, he started wandering into other residents' rooms and put himself at risk of assault. He also seemed to have lost the ability to feed himself. He was sent to the ER and there was admitted for failure to thrive. And then what we decided to do and what we concluded was that this individual was now truly out of scope for our hotel shelter. He was not able to care for himself. He was gravely disabled, and he was not independent with ADLs anymore. And so we made a decision to medically bar him from returning for being out of scope. And so what that entails is basically coordinating with the care team at the hospital and their social worker and their discharge planner that unfortunately returning to Mary Pilgrim Inn is not an option. And so he remained admitted for a long time. He was admitted from July of 2022 through February of 2023 for dementia with behavioral disturbance and failure to thrive. During that period, the team at Northwest Hospital was successful in getting a guardian appointed. And an interesting thing kind of happened. It's once guardianship was obtained for this individual, it seemed like the previous barriers to placement, specifically around his history and sex offender status, it seemed like that no longer became relevant. And he was successfully discharged to a memory care adult family home. There, he received geriatric care through Providence. And in June of, so about 4 months after he was placed, in June of 2023, he passed at his home on hospice care. So that's a case that I think highlights some of the challenges we face here, where we know someone needs a higher level of care, but there are barriers. And so our job ends up being to support someone while proper disposition is found for them, to minimize risk of further harm to them, and also really just to be a place where the wheels of the wheels can kind of spin and the gears can spin. Our team here got his involved with DSHS, and that really helped facilitate that process from the inpatient setting as well. And we're grateful that he was eventually able to achieve the level of care that he needed to and seemed to have passed in a peaceful way that was in line with his goals. I'm going to move on to a second case here. This one is called Chief Complaint. She's sleeping in the lobby. This is an 88-year-old female with a history of schizophrenia. She was referred to Mary Pilgrim Inn after an involuntary admission for grave disability. She had been a resident of the hotel for approximately a year and was typically seen in the lobby sitting on a chair or dozing in the sofa. She takes no medications and she doesn't wish to be outreached by medical or shelter staff, though dismisses us very politely. Thank you. I don't need any help. I'll let you know if I need help. However, something's changed now. She's now sleeping exclusively in the lobby and not going to her room. So we outreach her and ask her what's going on and try and talk to her. She endorses that she's feeling quite paranoid that there's poison gas in her room, and she does not believe it's safe to be in there. And that's why she's decided to sleep in the lobby. We contact her adult son. Contact information is in the chart, and he tells us more about her. She was previously a nurse with a long-term diagnosis of schizophrenia and a pretty good functional status for a long time. However, about 10 years ago, so in her 70s, she walked out of her apartment abruptly and expressing concern of poisoning in her house, specifically there being poison gas in her home. She was subsequently had some involuntary treatment admissions, some ITAs, and was placed in an adult family home, but she walked away from it again due to similar concerns for poison gas. And over the last 10 years has had many involuntary psychiatric treatment admissions. So when you hear that someone's had a lot of involuntary admissions, it's sometimes really helpful to go back and dig in the charts to see what was done, to see what the thought process was, and also to learn how she kind of fell through the cracks again, or how her status kind of resetted to grave disability in the outpatient setting. It seemed, these are quotes from the chart, but that during her admission, she did not seem to benefit from anti or poisoning her. It was concluded that the risk of compelling medication on this particular patient outweighed the potential benefits, and that her symptoms are likely refractory to treatment. And then here on the right, attempts were made to secure placement in an adult family home. However, this individual was very cognitively intact and knew how to advocate for herself. She talked to her attorney and said she wanted to have a hearing to leave the hospital. And as a result, the petition was dismissed and she was discharged from the hospital. Um, and you can also really appreciate the kind of the grief, the frustration that her care team felt. Um, in writing their discharge summary. As of the writing of the summary, she has already returned to the ER. So she discharged kind of against medical advice and was back in the ER even before the discharge summary could be signed. Her baseline is grave disability. And so this is kind of the status of things when we got to know this patient. She had gone through a lot of the typical processes to help someone get debilitating mental health illnesses treated and to pursue appropriate placement. It just didn't seem to be working for her. So how can we help this person? How can we help this elderly female with treatment-resistant psychosis and grave disability who has not yet met grounds for long-term involuntary placement? Grave disability is a term we use a lot, but this is the definition in Washington State. It's the result of a behavioral health disorder that leads to a failure for a person to provide for his or her essential human needs of health and safety, and is a severe deterioration of routine functioning. This person is gravely disabled. She was not able to access shelter that was provided to her, right? She has a free hotel room and bathroom available to her, and she cannot use it. She sometimes leaves the hotel and chooses to sleep on the sidewalk. She's not taking medications, and she's disabled due to her untreated or treatment-resistant mental illness. She's elderly, she's frail, she has mobility impairments. While at the shelter here, she fell and broke a wrist, and prior placements in adult family homes have been unsuccessful, as were involuntary treatment admissions. She would not agree to be started on medication, and it was thought not appropriate to compel those medications. And pending for self-neglect for this person. But again, she just seemed to be falling kind of in this gray space where there were not legal grounds to help her, involuntarily help her. And she did not wish to be helped. So sometimes the best options for individuals are not available. This person needed an adult family home, but it wasn't an option to her because she didn't want it and she was walking away from it. Sometimes our job is to provide our patients with choices, and we cannot force them to make the right choice or what we think is the right choice. In that setting, our goals are to minimize additional harm. We decided it was okay for her to sleep in the lobby because we could see her promptly if she has a fall. She can use the restroom in the lobby and she can access meals and medical help from the lobby. And so we thought for harm reduction purposes, it was acceptable for this person to sleep in the lobby. We continue to document her status for future placement and guardianship efforts. And our strategy really was to just keep trying. Things never stay the same. A DCR or an involuntary treatment admission may not have worked in the past, but that doesn't mean it won't work in the future. And we're trying to keep our options open. And a DCR was filed for her here during that time when she was sleeping in the lobby, but she was not detained. Things, however, like I said, always change. And shortly after this period when she was sleeping in the lobby, she left Mary Pilgrim Inn and was gone for a number of days, after which we filed a missing persons report. And she was found by police in Bellevue Square sleeping at the Starbucks there during the day and sleeping on a bench out in the open in Bellevue Square at night. She was brought to the hospital by the police and was diagnosed with a new diagnosis of heart failure, in acute decompensated heart failure, and was admitted and has been admitted since November of 2023, where she's awaiting guardianship and placement. Of course, while she's in the hospital, she's receiving excellent care. She's receiving food, nursing care, unfortunately, is still declining medications. But she is cared for and she is safe where she is right now. And though this isn't really a particularly satisfying outcome at this point, her needs are being met. And sometimes that's the best we can hope for. And in this case, it took a lot of groundwork and a lot of to agree to hold her involuntarily for a long period of time. And that's her current status. And the hopes are that she'll be placed in an appropriate facility soon. So not every case we deal with here at Mary Pilgrim is a ethical conundrum or gut-wrenching case. So I'm going to pivot to a little bit of a lighter case. And this one is I call minor mystery. This is a 63-year-old man with schizophrenia with Parkinson's disease who presents for wound care. So this was his wound on initial presentation to the medical clinic. He has a history of chronic homelessness, of alcohol use disorder, and of stimulant use disorder. And he was recently diagnosed with Parkinson's disease and started on Sinemet, which is currently being up-titrated. As you can see, he has a chronic wound on his right medial shin, just above his ankle. He has some mild venous stasis. He has no history of diabetes. This wound was extremely tender, and you can see was not clean. And so I cleaned this up on initial assessment and just based on some purulence here and some erythema, treated him with antibiotics for purulent cellulitis. So on follow-up, he's seeking wound care from our medical staff 1 to 2 times per week, which is probably enough to start seeing some improvement with that, especially if it's twice a week. It's treated pretty typically for a venous stasis wound with aloe vesta soap and water. We're using Medi honey for the wound. We're dressing it with a Mepilex border dressing, so a very standard dressing for a venous stasis wound. Securing it all with Curlex or roll gauze, and using compression socks to address the venous stasis, which is what we think is the driver of this wound. But a month later, the wounds are cleaner, but they're still very tender. They're actually getting a bit larger, and there's new ones popping up somewhere else on the leg. So the question is, why won't his wounds heal? And so I decided to pay a house call. She's a podiatrist at Harborview, practices at Adult Medicine and Hobson Clinic. And one of her sayings or teachings to me is if the wound is not progressing, you must keep looking. In other words, if it's not getting better, you're not treating the underlying cause. The patient had not sought wound care that week, so I outreached him at his room, and I found him sleeping in bed like this. And so what we saw here was that this patient was a little bit underweight and had some pretty bony knees. The the medial condyle on his tibia was very prominent. And it turned out this is how he was sleeping every night on his side with those bony prominences from his left leg really resting, exerting pressure on his right shin. And so this was not a venous stasis wound. These were actually pressure sores. And I did some reading about this after we saw this, and it's pretty interesting. I think we typically think of Parkinson's disease as of dysregulated and involuntary movements. We classically think of Parkinson's as having a tremor, but really Parkinson's disease is also associated with decreased spontaneous movements in bed and a decrease in positional changes that we all do, for instance, when we're sitting for a long time. And that's associated with an increased risk of pressure sores. And so coming to him, paying a house call, and trying to look a little bit more broadly for additional causes driving this wound really changed the treatment course. And so what it meant was the proper treatment for this was not necessarily compression uh, for something like a venous stasis wound, but rather needed offloading and padding. And so we were able to order Sage boots through DME that he was able to wear at night and that supported his legs and allowed those wounds to heal pretty quickly. Okay, and now I'm going to move on to a final case here. This was a case of provision of home hospice services in the hotel shelter setting, and a case that unfolded at the Red Line Hotel in Renton about 3 years ago in collaboration with the Harborview full team. There's 3 members of that team right now. Michael Light is the social worker on that team. Kelly Campbell is the ARMP and provider on that team, and Joe Hufford is the nurse on that team. And they were instrumental in figuring out a treatment plan for this patient. It started with that when a 56-year-old woman arrived at our hotel shelter late at night. It was a cold and rainy night after two back-to-back ER visits for frequent falls. She had previously been discharged from a women's shelter due to alcohol relapse of alcohol use, and had been sent to a detox program. The women's shelter that she had previously been placed in on the east side was not low barrier harm reduction focused, so you could not drink alcohol or use substances there. So that was a criteria for discharge from there. And she was having frequent falls associated with intoxication at the hospital and was sent to a detox. Unfortunately, however, she was pretty promptly, after 3 or 4 days, discharged from the detox program. After she had completed alcohol detox, she was still falling, and they weren't able to care for her. So they sent her to the ED from the detox program. Um, and after that first visit, she was very quickly cleared and discharged back to the street, and then returned to the ER again after being found down on the sidewalk, and was referred to the hotel shelter from the emergency department at that time. So we try to get to know her. We engage her medical staff on intake, and she has a pretty remarkable physical exam. She has masked facies, she has bradykinesia, she has shuffling gait, and she has pretty profound cogwheeling rigidity on exam. So she's given a presumptive diagnosis of Parkinson's disease, and I started her on a trial of carbidopa-levodopa while the rest of the workup is pending to see if she has a positive therapeutic response to Sinemet. And on follow-up a week later, she's noted to have a very significant improvement. She's not falling anymore. She's moving a lot more smoothly. You see a significant improvement in her facial expression as well. She's smiling. And with these improvements in functionality, she becomes a lot more social in the hotel, uh, with other residents. She starts dating another resident of the hotel. And unfortunately, though, her alcohol use escalates, and it escalates pretty publicly. She's seen drinking publicly frequently. And unfortunately, associated with that as well, she declines to engage in further outreach or follow up with medical staff. We do continue to check in with her in the public spaces and say hi and see if she has any needs. And we continue to refill her medications, such as her Sinemet for Parkinson's and gabapentin for alcohol use disorder. But otherwise, we're taking a pretty low-key role in her care based on what she's telling us she wants or needs. Unfortunately, though, she suffers a very significant decompensation and decline in her health. 4 months later, a welfare check is done on her because she hadn't been seen in the lobby for a couple days, and she was found unconscious in her room. She was transported to the ER emergently and admitted for decompensated cirrhosis, which is a new diagnosis, with hepatic encephalopathy, malnutrition, and SBP. And during her admission, after kind of she's acutely treated for those things and her mental status improves, she expresses a desire to continue drinking alcohol. And she's subsequently discharged back to the hotel shelter with plans for GI follow-up and recommendations to abstain from alcohol use. Upon her return, we outreach her again, and we're more focused in our outreach, though. We're focused on her values and to discuss what her treatment preferences are. Because in the hospital, she really was pretty clear about some of those desires, and we wanted to get them formalized, and we wanted to come up with a treatment plan that was in line with her goals. She confirmed her preference to continue drinking alcohol and understood that this would hasten her death. She indicated that she did not want CPR, she did not want to be intubated, and wanted comfort measures only, and did not wish to be returned to the hospital under any circumstances. She declined to reconnect with family members due to embarrassment regarding her diagnosis of cirrhosis secondary to alcohol use. And after having this goals of care discussion and completing a pulse form with her for the homeless team that I mentioned, and she was outreached by them at the hotel shelter. After consulting with our palliative care colleagues and shelter staff, she was enrolled in home hospice services through Evergreen Hospice. And shortly thereafter, it was actually really amazing how quickly it happened. Within a couple days, she started receiving hospice services in the hotel shelter. I was the hospice doc as on-site physician, and she was provided with a hospital bed and a daily bath aid. She had weekly nurse visits, often twice a week to help her. And without that care, she was very weak and was declining very rapidly. She was bedbound and dependent for all activities of daily living. But her days were still filled with things that she valued. She was taken outside at least once a day for at least an hour a day in her wheelchair by her caregiver to socialize with other residents of the hotel. She continued to have strong relationships with other residents of the hotel and really was not isolated, which I think is a beautiful thing. She continued daily cigarette use. She only smoked 2 cigarettes a day and continued drinking alcohol, though it was actually very little. It was more for comfort. She consumed less than 1 beer a day and drank it with a straw. Approximately 2 weeks after beginning hospice services, the patient reported abdominal pain and had small volume hematemesis. We contacted the hospice nurse, and she was administered a single dose of Zofran for nausea and a single dose of oxycodone, 5 milligrams for pain. And then on recheck 1 hour later, was found to be deceased with large volume hematemesis. So this was a very emotionally involved case, but one where I was really proud that we were able to offer home health services to someone in their hotel shelter, and provide care and a path towards the end of their life that was in alignment, very explicitly in alignment with their goals. Being unhoused or having unstable those goals and to accessing palliative care or hospice care. Uh, if you are unhoused, how can you receive home hospice services? For instance, if you're living in a tent, it's impossible. If you have a substance use disorder or wish to continue using substances, that often makes it such that you cannot be accepted to residential or inpatient hospice units. Or similarly, if you have a history of incarceration, or of behavioral problems due to untreated or treatment-resistant mental illness. Those are big barriers to placement. A lot of people with chronic homelessness also don't have primary care who can help coordinate or refer them to hospice services, um, as additional barriers. And then something that we see in our patients sometimes that I think can really be a barrier to having a frank goals of care discussion is that a lot of our folks are in survival mode. If we look at this Maslow's triangle of needs, a lot of our folks are really focused on obtaining shelter and food right at the base and are not necessarily in a space for them to think about their preferences, their comfort, and actualizing their personal goals in regards to their health. I think hotel shelters with medical services like ours can meet people's basic needs and create a safe space to have that discussion and to plan for the future. And also, we can provide a supportive physical setting for home health services. So, I hope to do a lot more of these in the future for our residents who need them and want them. So that's it for my cases and for my talk. I really enjoyed speaking with you, and I really hope you enjoyed hearing about some of the work we do here at Mary Pilgrim Inn, a little bit of background on homelessness in our community. We discussed some cases of aging, disability, and schizophrenia, um, and some of those ethical challenges that we face here as a care team for those individuals. Talked about a little bit about a medical mystery, but really the learning point there is that Parkinson's disease increases risks of pressure sores, and that wounds that are not healing, given typical and standard of care, should make us look for alternate drivers, such as a pressure injury here in that patient with Parkinson's disease, and also discussed how we're able to provide hospice in the circumstances, and how that can help our patients meet their goals. I wanted to thank a lot of people. I want to thank the patients for honoring us with their trust and their care. The Mary Pilgrim Inn clinical team and shelter staff. This list is long and longer than I have listed here. G. Che is the nurse practitioner here. Angie and Chad are two nurses. Sam is our shelter manager. Natalie is the supervisor for the case managers. Richard Waters is the medical director of DESC. Our Harborview field-based teams provide the support and the resources and the knowledge and the supervision for us to do our work. Thanks to Ainsley Duncan, Jared Klein, Melissa Brown, Tricia Madden, and Cindy Marr for their leadership. And also, I wanted to explicitly call out the Harborview Palliative Care for the Homeless team, Michael Light, Joe Hufford, and Kelly Campbell for their tremendous help. They help with a lot of our patients here facing terminal illness and end-of-life care. And thank you so much. And here's a QR code for evaluations. And I think we have some time for questions.
Great, thank you so much, Russ. We have a lot of questions and comments. I'm wondering if you can see the chat or if you would like some help starting with Shay around L811.
Yes. So yeah, thank you, Shay, for this comment. Shay's comment is that there's a marked disproportionality of people of color living unhoused, especially Black people. That is absolutely correct. Um, uh, Black members of the King County community are a relative minority of the community and are vastly overrepresented in our population who are unhoused and those facing chronic homelessness. That is absolutely true. The demographics of MPI, we seek to match the racial demographics of MPI to the demographics of the broader King County population who are experiencing homelessness. And as a result, we do give preferential admission acceptance status to people of color, both Black individuals who are Black, people Latino background, and as well, especially people of American Indian or Native American heritage, those individuals. The next question was, can you provide IV medications? So we can do IM medications here, intramuscular medications. What that looks like here is we provide a lot of long-acting injectables for folks, and that's really our standard of care and our goal of care for anyone with psychosis who could benefit from a long-acting injectable. We try to prescribe those and administer those to people here on site. We can treat syphilis, for instance, with penicillin. We can treat infections with ceftriaxone injections we have here, IM injection. We can treat pain with Toradol, but IVs are not currently within scope of Mary Pilgrim Inn Clinic. And similarly, we don't do IV fluid resuscitation, but we do oral volume resuscitation with oral rehydration solutions. The next question is, can you speak more about the Apple AirTags? Yeah, I mean, this was kind of thinking for that patient who was wandering off and getting lost. And the discussion was really triggered when he had been left at a bus stop all night after discharge from the ER. It's often hard to coordinate discharges from the hospital late at night. There's no medical staff here on site. And it was really sad to think that this elderly person with dementia was just left out in the cold all night long. He was scared, and he didn't want that to happen again. And we talked about, getting him a life alert, and we put those orders in, and they were just delayed. And in the meantime, the idea just came up, hey, if he agrees, can we give him an AirTag necklace and link it to the shelter phone? And he wanted that, and we did that. And so that just allowed us to find him when he wandered off. And we only used it once or twice, and he had wandered nearby, but shelter staff were able to find him very promptly and able to bring him back. One time we used it was when actually he was lost in the hotel. he had gotten into someone else's room, and we didn't know where he was in the hotel, and we were able to just find him on site. Um, yeah, and Shay brings up a more sustainable idea is to provide folks with a medical alert bracelet with name and contact information. We do that as well for folks with dementia here. We provide them with a bracelet or a necklace that has our address and phone number on it so that they can be returned to us if they wander off. Question from Amy, does Mary Pilgrim have social work supports to begin the guardianship process earlier for folks? We do. And we do get that started. It just seems to move faster from the inpatient setting. I can't say much faster because it's still always on the order of months. But for the folks who were the two cases here, both the elderly male and female, the guardianship process had been started through Adult Protective Services um, early in their course here. And it just seemed like those processes were kind of on hold and we're not going anywhere. Um, on the other hand, I think the pressure that can be exerted from inpatient units sometimes because a bed is being occupied can drive that process to be a bit faster. Shay also mentions the GRAT team to be used to accept referrals for homeless individuals. Um, There was a question about the gap between grave disability and meeting criteria for involuntary placement. Yeah, so grave disability, I'm not an expert on this, but from my experience here, grave disability, we have success utilizing grave disability as a justification for an involuntary admission. But if during that admission, they kind of are cleared by psychiatry and are deemed to have decisional capacity regarding their disposition, they're then allowed to leave the hospital and allowed to discharge. And that's kind of the situation where a lot of these folks get stuck in, is it's clear that they're gravely disabled and they're taken into the hospital, but they clear sufficiently that they're discharged and they're not kept indefinitely. There's a question about the ethics of healthcare providers being guardians for individuals in this population. Yeah, I think that is a big issue. And as far as I understand, for their patients. So I am not a guardian or decision maker for anyone here on site. And I think that handles last question from Dr. Reed. We have a lot of difficulty interfacing with outpatient mental health records. How does your group approach that? That is a huge problem. And often it's over the phone. I comb the medical records trying to find a contact number or a team there, ask the case managers here to dig as well. And then often it becomes pretty old fashioned, leaving messages for people on the phone and trying to receive faxed medical records. But there's quite a bit of sleuthing and detective work that needs to be done often to flesh out someone's past mental health history.
Great. Well, thank you so much, Russ, for being with us today. As you can see, lots of kudos in the chat. Amazing talk. We really appreciate the amazing work you've been doing.
Thank you so much. Thank you for the invitation, Ruru, and thank you for Departments of Geriatrics for inviting me. It was a pleasure to talk to you.